My understanding of low back pain is, as with all pain, that pain is real. Even though it's not visible, you can't see people's pain. It's a real and normal experience. There is a difference between acute pain, which is normally pain that's only been there for less than 3 months, to persistent pain, which is longer than 3 months. But with persistent pain, it's more about the oversensitized neurosystem, the nervous system, which is trying to protect you, but in doing so is overprotecting you because it's getting missed messages, it's just overprotecting, it's just wound up. So it's more about dampening down the sensitized nervous system in persistent pain.
My understanding of low back pain is that it can be triggered by often a very physical injury, but over time that initial injury heals, and so if someone does progress to chronic pain, meaning pain that persists beyond 3 months, then there are a greater range of factors that are associated with that, and a lot about the role of the nervous system and the interpretation of the brain comes into play, but also other factors to do with thoughts and emotions, environmental factors and so forth.
The other way in which we like to empower our patients is to get them to stop looking for that golden diagnosis that's going to make a difference, And a lot of times they don't start looking for that, but they end up looking for that when they get so many different opinions and are sent from pillar to post trying to find the answer. And they actually didn't start looking for an answer, they just wanted their pain to end. But then it becomes they get caught up in the system.
There's more to persistent pain than just a tissue injury or a mechanical injury in their bodies, that there's a whole lot of other stuff going on which contributes to their pain experience. And that's why we need a lot of people to help look at a lot of those different areas.
In the chronic frame, treatment does differ because really it often requires the person with the pain to address a broader range of issues, and often it does amount to preparedness to change lifestyle, whereas in the chronic pain, the longer term example, it's more about active treatments, meaning the person changing their behaviours, changing their lifestyle, thinking about eating well, moving well, and thinking well is a threefold way to look at that.
So when I think about advice for people living with lower back pain, the number one thing that comes to my mind is information. We often use in the clinic when we work with people the term knowledge is power. The more you know, the more you can do. And so when we think about people when they're getting treatment for persistent or chronic lower back pain, it's about understanding as much as they can. So we work with people to give them information about how pain works and then tailor it to their individual situation, and trying to use and apply that knowledge to do more of the things they want to do. So often when people come to us, their first goal tends to be, well, what can you do for my pain? And sometimes, as a first or primary goal, we can't always make big changes in that pain immediately. But what we ask them afterwards is, well, what do you want to do if you didn't have the pain? And they'll often bring up things like, I want to do more with my grandchildren. I want to go back to work. I want to do cooking and cleaning, the everyday straightforward things a lot of people take for granted. And so we say, well, then let's focus on that. And so it's about education about how you can get to that point. A lot of the time it's that education gives them confidence to do things they never thought they'd be able to do.
The sort of advice I would give someone who has persistent or chronic low back pain really starts with the whole education process, and that's as a team what we would set out to do in meeting someone for the first time. I think it's very important if that person can get an understanding of the latest scientific approaches to the question of why pain persists, and also the latest understandings and the best way to treat that. So I think education is really a fundamental first step to give the person the information that they need to set out on their journey.
For someone who has persistent low back pain, I think one of the big things is knowledge and understanding that it may not be so much with damage or issues at the tissues, but more about a brain that's overprotecting you. And I think the good thing to know is that it can be changed. There's a lot of recent research about neuroplasticity, and that the brain is so plastic and it's so changeable that you can dampen down that protective system and change the danger messages which are being sent up and analysed. It's also important to know that it's in context, that everything is taken into context. For instance, someone who's a violinist who may have persistent pain in their hand are affected more than, say, a footballer who doesn't use their hand. So a lot of context is involved as well.
The difficulties people face with the experience of chronic low back pain can be quite diverse. I think there are many individuals who experience this, and each person is different in a way. I think part of the challenge is the interaction with the whole medical system. And I think from where I sit as a doctor working in pain medicine, that one of the biggest issues is the system often can focus people down very much onto a narrow approach to their pain. It can potentially focus someone down just onto the structures of their body and onto the disc that is looking abnormal on the MRI scan, for example. And so that person in the midst of a system like that faces the challenge of how to broaden out their approach when the system, perhaps the surgeon, perhaps the GP who might focus down on medication-based management, are going in a narrow direction. So I think that's one of the biggest things, the challenge of keeping broad. Also, I think there's the challenge of maintaining hope is a particular aspect that we explore with our service. And I think if people are focused on the fact, for example, that I've got a broken back and it's injured beyond repair, the prospect of simply learning to cope with that doesn't seem very optimistic. But one of the things with the new theories about chronic pain and the role of the brain and the nervous system, neuroplasticity as we talk about, is that does give a more optimistic flavour. And the whole question comes out of, can someone learn to retrain the brain and the nervous system, damp down their immune system with a view to slowly reducing pain over time? That becomes a much more optimistic frame.
The other thing about lower back pain is that it's so associated with depression, it's so associated with anxiety. It has a lot to do with our lifestyle, our work, our problems that we might have with relationships, and basically every time we're in fight-flight, which is very often throughout the day in our busy lifestyles, that helps to drive our pain further. So it needs a very multimodal approach, and it also needs for the patient to be in charge, which is a struggle sometimes.
A lot of people are worried about seeing a psychologist and that it might mean that they're crazy or something like that, but they're not. They're normal people experiencing real difficulties in their life, and most people find it hard to cope with a lot of those things. So it's just trying to help people cope with what they're experiencing on a day-to-day basis.
Let me make a comment about which treatment should be avoided for low back pain. Really, if we're looking at the longer-term low back pain side of things, the treatments of any sort that we're trying to get people to gradually defocus on and move away from are the passively received medical treatments or the passively received any other treatments. Really, the main game in chronic non-cancer pain or chronic back pain, to take that particular example, the main game is about retraining the nervous system. And for the person to retrain the nervous system, they need to make active changes themselves. So really we're trying to steer people away from medication. We're trying to steer them away from injectable procedures and surgery. There may be a very small selective place for those treatments. We say to people coming into our service that there may be, perhaps in 5% of people, a role for surgery in chronic pain, but the other 95% of people, they are better off served by the active self-management approaches, as we call them. And I would say the same thing for physiotherapy treatments. The role of the physiotherapist in chronic pain becomes much more about the coach and the hands-off treatment, so the guide to how to move in a controlled and a mindful way, because the hands-on traditional physiotherapy approaches may be beneficial in the short term, but can be counterproductive in the longer term if they disempower someone's engagement with the active approaches. About half of the people get very substantial reduction in their levels of pain, which wasn't what we were thinking to begin with, but I think to weight that appropriately, we need to be saying to people, if you are coming and doing some work through a pain service, and particularly if you are looking at some of these self-management lifestyle approaches, it isn't that this is simply about learning to manage an existing level of pain. This actually, in many situations, can result in a lower level of pain. So I think there is a lot of hope in that. And I think although we don't see it commonly at the best end, we do see some people who get complete abolition of pain that may have been there for 10, 15 or 20 years. And so in working through these issues, I think it's good for people to keep in mind that in retraining the nervous system, they can get benefit. We don't have crystal balls, so hard to tell exactly how much benefit in an individual case. But in the new era, we are certainly looking much more about the possibility of these lifestyle approaches, bringing pain reduction slowly and steadily over perhaps a 6 to 12 month period and beyond.